Hello everyone, I am Ahmed Gowaid. I'm a lecturer of psychiatry, and today I'm going to present a very important topic in psychiatry, which is emergent psychiatry. At first, emergent psychiatry or a psychiatric emergency is a disturbance in the thoughts, feeling, or action threat in the people environment and require immediate treatment. Characteristics of the psychiatric emergency: a condition or situation that makes the patient and the relative seek immediate treatment, a condition that characterized by disharmony between the subject and the environment, a condition with sudden disorganization in the personality which affects the socio-occupational functioning. When we treat a psychiatric emergency, our objectives are to safeguard the life of the patients, to bring down the anxiety of the family members, and to enhance the emotional security of the others in the environment. These are examples of the psychiatric emergencies like catatonia, suicide, panic attacks, violent or excitement, drug or alcohol overdose, delirium, iatrogenic causes like serotonin syndrome or neuroleptic malignant syndrome. At first, the most important topic is suicide or deliberate self-harm. Suicide can be defined as intentional taking of one's life in culturally non-endorsed manner, where attempted suicide is considered as unsuccessful suicidal act with a non-fatal outcome. And suicide is considered the commonest cause of death among psychiatric patients. Suicide account for from 1 to 2% of total mortality rate. Thoughts are common in females, while suicidal attempts are more common in males. Commonest methods used: ingestion of poison, which is common in female, hanging, which is common in male, burning, drowning, falling from heights, and jumping in front of trains or vehicles. Etiology of suicide can be related to psychiatric disorders like major depression disorders, schizophrenia, psychotic disorders, substance abuse, personality like borderline personality disorder. Sometimes it can occur out of dementia or delirium. Also, physical disorders like chronic or incurable physical disorders like ADHD or cancer. Psychosocial factors like failure in exams, loss of loved one, harassment, marital problems, and isolations. Regarding the risk factors, suicide increased by these risk factors like being single, age more than 40, being male, being depressed or psychologically unstable, have or had previous suicidal preoccupation, stressful life events, chronic illness, feeling forceless. The warning signs of suicides are being depressed or sad most of the time, feeling hopeless or expressing hopelessness, withdrawal from family and friends, sleeping too much or too little, making overstatements like "I can't take it anymore" or "I wish I was dead," losing interest in most activities, making out a will, giving away prized possessions, neglecting personal hygiene, being preoccupied with death or dying. Regarding management of suicide, at first, we need to be aware of the warning signs, monitor the patient's safety needs, like taking all suicidal threats or attempts seriously, search for toxic agents like alcohol or drugs, don't leave the drug tray within the reach of the patients, remove sharp instruments from the environment, remove straps and clothing like belts, don't allow the patient to bolt the door from inside. Someone should accompany to the bathroom. Patient should never be left alone. Spend most of the time with the patient and encourage him to ventilate his emotion and talk about suicidal plans and suicidal methods. Enhance the patient's self-esteem by focusing on his strengths. Also, we need to acute psychiatric emergency interview. We do counseling and guidance for the patients and his family, treatment of the underlying psychiatric disorders, and last, ECT as an emergency treatment for the suicide. This question, you need to answer this question before you can continue to listen to the next part of the lecture. Second topic is neuroleptic malignant syndrome. Neuroleptic malignant syndrome is a life-threatening idiosyncratic reactions to antipsychotic drugs characterized by tetrad of fever, altered mental state, muscle rigidity, and dysautonomia. Regarding the epidemiology, the incidence rate of neuroleptic malignant syndrome can reach to up to 3% among the patients taking antipsychotics. Regarding the risk factor, gender is considered the risk factor, where incidence is more common in males than female, with percentage 2 to 1, while age is not considered a risk factor. Medication associated with increased risk of neuroleptic malignant syndrome are atypical antipsychotic, especially those with high potent drugs like haloperidol or droperidol or bimozide. Atypical antipsychotics like clozapine, olanzapine, risperidone, zabrazidone, aripiprazole, where incidence of neuroleptic malignant syndromes is less than that of the atypical antipsychotics. Other dopaminergic drugs like metoclopramide, bromethazine, which are antiemetics. Also, studies found that rapid withdrawal of anti-Parkinsonian drugs can induce neuroleptic malignant syndrome, and called neuroleptic malignant-like syndrome, that is characterized by mydriasis, diaphoresis, agitation, tachycardia, autonomic instability, increased bowel sounds, hyperreflexia, tremors. Regarding the pathophysiology, no exact cause is found to explain the mechanism of occurrence of neuroleptic malignant syndrome, but the most accepted theory is dopamine antagonism theory, where D2 blockade in the nigrostriatal pathway is accounted for rigidity, while D2 blockade at hypothalamus is accounted for hyperthermia, and D2 blockade in the mesocortical or frontal lobe is accounted for altered mental state. This table lists the criteria required for diagnosis of neuroleptic malignant syndrome, which are treatment with neuroleptic drug within 7 days of onset or within 2 to 4 weeks for depot injections, presence of hyperthermia, presence of muscle rigidity, presence of 5 of the following: change in the mental state, tachycardia, hypertension or hypotension, leukocytosis, metabolic acidosis, increase in the creatinine phosphokinase, presence of myoglobinuria, diaphoresis or sialuria, tremors, incontinence, tachycardia or hypoxia, tachypnea or hypoxia. Also, exclusion of other drug-induced systemic or neuropsychiatric disorders. A lot of serious complications can be associated with neuroleptic malignant syndrome, like rhabdomyolysis, acute renal failure, acute respiratory failure, seizures, brain damage, myocardial infarction, disseminated intravascular coagulopathy, hepatic failure, E. coli fasciitis, and sepsis. Differential diagnosis of neuroleptic malignant syndrome includes infectious disorders like CNS infections like meningitis or encephalitis, brain abscess, generalized sepsis, psychiatric or neurological disorders like idiopathic malignant catatonia, agitated delirium, benign extrapyramidal side effects, non-convulsive status epilepticus, structural lesions, especially those of the midbrain. Also, toxic or pharmacological drugs like anticholinergic delirium, salicylate poisoning, malignant hyperthermia that occur with inhalational anesthesia, serotonin syndrome, especially those with monoamine oxidase inhibitors, triptans, substance of abuse like amphetamines or hallucinogens, withdrawal of dopaminergic agonist or dopamine agonists, baclofen, sedative hypnotics, and alcohols. Also, differential diagnosis include endocrinal causes like cytotoxicosis and pheochromocytoma, environmental factors like heat stroke. Regarding the investigations, lab findings include increase in the white blood count, increase the level of creatinine phosphokinase, increased liver enzymes, metabolic acidosis, increased renal functions, presence of myoglobinuria that is usually associated with renal failure. Regarding the treatment, first we need to admit the patient to the ICU. We need to protect the airways and his circulation, and sometimes we can give the patient IV fluids or intravenous fluids to correct the dehydration. Also, we can give the patient intravenous benzodiazepine to control agitations, and we need to discontinue the offending drug. We need to use cooling device and antibiotics to control hyperthermia. If rhabdomyolysis and myoglobinuria are present, then alkalization of urine or dialysis may be required. Dopaminergic drugs like bromocriptine and amantadine can be used. Also, muscle relaxants like dantrolene sodium is used. Electroconvulsive therapy is sometimes used if medication failed to improve the condition. This quiz 2. Please answer this question before go to continue the lecture. The last topic is catatonia. Catatonia is a neuropsychiatric syndrome characterized by unique combination of mental, motor, vegetative, and behavioral signs. Clinical picture of catatonia include stupor, catalepsy, waxy flexibility, mutism, negativism, posturing, mannerism, stereotypy, psychomotor agitation, grimacing, echolalia, and echopraxia. Types of catatonia include: first, akinetic catatonia that is characterized by immobility, staring, mutism, rigidity, and withdrawal. Excited catatonia or catatonic excitement includes that is characterized by agitations, restlessness, purposeless movements. And the last type is malignant catatonia that is characterized by delirium, fever, rigidity, and sweating. Catatonia can occur out of mental disorders or medical disorders, and at first we need to exclude delirium before gives a diagnosis of catatonia. Potential causes of catatonia include those out of medical illness like seizures, CNS infections like encephalitis or meningitis, central CNS damage like in case of stroke, neuroleptic exposure, corticosteroid exposure, postpartum state, iron deficiency. And it can occur out of psychiatric disorders like major depression disorder, bipolar disorders, psychotic disorders like schizophrenia. Complications of catatonia include falls, injuries, and accidents, malnutrition, dehydration, increased risk of deep vein thrombosis out of immobility, high risk for pulmonary embolism, also out of increased risk of deep vein thrombosis and immobility, ulcers, and various other medical complications. Investigations: there is no pathognomonic lab finding in catatonia. The lab evaluation should be used to rule out an underlying medical condition. And appropriate medical tests may include CBC, electrolyte levels, brain imaging, and EEG if we suspect presence of seizures. Regarding the treatment, hospitalization must be done to take care of the patients, maintain nutrition with intravenous lines or feeding tubes, identifying and correcting the underlying etiology. Benzodiazepine like parenteral lorazepam can provide temporary improvement in symptoms and facilitate patients' ability to communicate and take care for themselves. And the last, ECT. ECT is appropriate for catatonia, especially if the catatonia is life-threatening, like inability to eat or to take care of oneself, or has developed into lethal or malignant catatonia. The exact mechanism behind the efficacy of ECT is unknown. And thank you.